I
don't have to do the social.
Okay, everybody, last chance to say hi to everybody before I mute you all.
Hi.
Hi, Will.
Hi,
everyone.
Okay, everybody, you are now muted and we are going to formally begin our program. Welcome everyone today with our conversation with our featured guest, Dr. Tanya Schreibman. Before we begin with her though, just a little bit of word of business. For those who are not familiar with enormous Zoom calls, we all need to stay muted. So that we don't interrupt our speaker or questioner when they are talking. And then when it's time for questions, you will all have a chance to raise your hand either through the device, it has a hand raising option, or just go like this and eventually I'll see you. Just keep it up for a long time. At any point, you do have the ability to unmute yourself, or you can send a chat to everybody if you want to convey a message, or if you have a question you want to ask, send it in the chat. Every few minutes, I do check the chats, and if there's a message, a pertinent message that needs to come through, that's a good way to reach me through the chat feature. You don't need to do any of these features. If you just want to listen, observe, and watch, that's all fine too. Today's program is part of a series of amazing friends. We are in the midst of that right now. We had a speaker a friend of Rabbi Elaine, whose book just came out about the mysterious name of God. We've got a speaker coming up, a friend of Rabbi Sheffrin's, who's a comedian in Jerusalem. And it's a part of an ongoing series where we are tapping some of our most extraordinary friends to share with all of you, with our congregation, with our community. And it is my great pleasure to share my friend, Tanya Schreibman. Upcoming events today, there is a social at 5 o'clock by Zoom, but on a different channel. You can just look at the back at the Tuesday email for that. We've got a class, I think, there's something going on Thursday, and I forgot what it is. I don't remember. But there's things going on. Sabrina Silverberg's program has started up. There is so much going on at Temple. Please check your Temple emails carefully. But I'm preaching to the choir because you all made it here today, which means you're reading your emails and you're showing up when you're supposed to. So well done. Today's program is going to be half about COVID and half about our extraordinary speaker. So without any further ado, I want to introduce her. And I say it's half about our extraordinary speakers because it's COVID that is the pressing question right now. But this is an opportunity to learn about one of the most fascinating and admirable members of our whole Sarasota community, who has volunteered her time. She served in Africa. She has spent a career helping truly those who were most in need in our American community. That is people who have suffered with the HIV virus and with AIDS. And so we're going to spend some time talking about her work in general so that we can know what's going on right here in Sarasota, actually. But then, since she's such a brilliant physician and expert in infectious disease, we're going to ask her questions about the infectious disease that we're worried about right now. And so let me then, without further ado, introduce our speaker. Dr. Tanya Schreibman completed her undergraduate degree at Cornell University. Not bad. Her medical degree at Cornell University. Not bad. And then at Cornell Medical College, she completed her internal medicine residency as well as infectious disease fellowship, both at Yale University. She is board certified in infectious disease with subspecialty interests in both HIV and hepatitis. She currently serves as medical director of CAN Community Health here in Sarasota. She's on staff at Florida State University and has affiliate privileges at Sarasota Memorial Hospital. She serves as chair of the Regional HIV/AIDS Council Medical Committee, as well as serves on the Florida Consortium for HIV/AIDS Research. Dr. Schreibman, on behalf of all of us at Temple Emanu-El and other members of the community who are here with us today, we want to thank you for taking time out of your very demanding schedule to reserve this afternoon for us. She has taken over her daughter's bedroom as the quietest room in the house to be able to speak with us today. Dr. Schreibman, please go ahead and unmute. And the way our program is going to go out here, I have here 13 questions prepared, and then we're going to be opening up the floor to everybody to ask your questions. So welcome, Dr. Schreibman.
Thank you. Thank you so much. It's an honor, and thank you very much.
So let's go and begin our first question. What drew you to infectious disease as a specialization?
So it was really largely my interest in HIV, which, can you hear me? I'm unmuted.
You're doing great.
Okay. So it was largely my interest in HIV that drove me to embark on this specialty in infectious diseases. Although, you know, it was interesting because when I made the decision to go into infectious disease, it was not a particularly popular specialty. It really still isn't. And if I would talk to anyone about it or mention that I've decided to go into this specialty, mostly people would kind of glaze over, and no one really asked a whole lot of questions. Either they didn't know what I was doing or didn't really want to know what I was doing. And now if I say that my field is infectious diseases, all of a sudden everyone wants to talk more. So, but in general, it's always been fascinating. It's ever changing. It's evolving. I found it challenging. It's multifaceted. But the bottom line is it was my interest in HIV that drove me to pursue that.
So when you started, you were not a hot ticket for dinner parties, but now you are, but there's no dinner parties.
It's very, very true. But here we are.
Yes. All right. So, I did not know that it was AIDS that actually, your interest in AIDS that drew you to infectious disease. This was a very different time, AIDS, when you were entering the field than where it is now. Can you tell us a little bit about what has changed in the treatment of AIDS and what that means for your practice?
So it's almost a whole different specialty at this point. You know, when I made the decision to go into HIV, it was essentially when people, as the patient said, it was like a death sentence, and they were pretty much told that they were positive, and they would kind of put together their affairs and felt that they were going to die. The people that were the luckier ones were on many medications, often 2 to 3 times a day, 20 to 30 pills that would often make them feel sicker than the infection, than the HIV virus itself. So and those were the lucky people that we were able to get on medication. And now I would say most people, especially people that are newly diagnosed, we give them a pill a day. We're moving in the direction even of injection medicine. Some of the research that I'm doing puts people on just an injection, and they take that every 4 weeks or sometimes every 8 weeks instead of having to take any pills. So it's really been revolutionary that way. But even lifespan, when we tell people now that they're positive, we usually tell them they can expect to live a lifespan as if they didn't have HIV. And that is just as important and just as big a change. When I entered the field, I was in my mid-20s, and I would say the average age of the person I took care of was probably 25. I was in New York, and it was mostly young gay men, and they were my age. And now I would say the average age, since people are living longer with HIV, is, I turned 50 last year, and I would say the average age of my patients are probably right around that point. I have many in their 60s and 70s, in their 20s, 30s, and 40s. But it's been kind of interesting to age along with my patients. And a lot of what I do is primary care, because the HIV is so controlled that it ends up being more management of other chronic issues, whether it's blood pressure or depression or a back strain or a respiratory infection. So it's changed a lot.
I had heard that you were actually pursuing a new board certification because your patients now are dealing with all the normal people ailments of getting old, which is this
Right.
whole new change. And now that you have to learn all of these things as your patients are aging.
Yes, because actually often a very small part of the visit is just people come in, and actually it's often at the end of the visit, they'll say, oh wait, what are my HIV numbers? Am I doing okay? Because we've spent so much time managing blood pressure and things that we just didn't worry about 25 years ago. Well, people were younger, so they didn't have the issues. And the last thing we cared about was the other, it wasn't relevant at the time. So yes, I've had to relearn a lot, and a lot of it has been just contacting colleagues or asking people and absolutely honing up on all of my internal medical skills. So it has changed a lot, but that too keeps me, it makes it challenging and interesting as well.
So I want to ask you about what really drew you to address AIDS. So I want to picture your parents for a moment. Their daughter
They're here.
just tells
I saw them
them,
somewhere.
their daughter says, I'm going to medical school. They're like, hooray, every Jewish parent's dream. And then says, and now mom and dad, I'm going to spend all my time with patients with AIDS. That had to be a surprise for you. That's not where most people are going and dedicating their lives. What drew you and why did you feel the call that you had to serve people with HIV?
Yeah, it's funny. You cut out a little there. Hopefully I'm not speaking over you, but it's funny you would use the word feel the call, because it was almost like a calling for me. And it's also interesting because over all the years of where I've worked at the different locations, or even where I'm at now, so many of the people involved with HIV, so many of the staff or the nurses or even other doctors have a story, like they lost someone to HIV, or they themselves are positive, or their brother died of AIDS. And I never had that personal story, but there was something about the pandemic at the time that I just found very challenging, and there were people who needed the help. There was so much research going on, and there are so many changes that there was something about that really interested me. It also, taking care of people with HIV there's so much psychosocial help that is involved just with that community, and that was something that always interested me. And I think in a way it allowed me to be kind of an activist in my own terms. I wasn't someone who, I feel very strongly about my convictions, and it's a bit of a mission for me, but I'm not someone who is going to be necessarily out there on the street with signs, although we are putting up some signs in our front yard right now, but generally speaking, that's not how I am. But it allowed me to kind of be an activist and to do something that I feel passionate about and follow my convictions that way. So yeah, it wasn't one specific incident, but it feels like a calling for me.
It is a calling. And look, you're able to make a living and support your family, and that's wonderful. But there's clearly more glamorous, but maybe not more rewarding lines of work. And I would just say, as a member of our Sarasota community, I'm very grateful that that segment of our population has someone to turn to, and that you're here to serve. And thank goodness for that. Tell us about where you work. What is CAN Community Health?
So CAN, it used to be, many people were familiar with it when it was CAN, or Community AIDS Network, and the name expanded to CAN Community Health. And it was a small, probably 25 years ago it was founded. I've been there 15 years, and when I joined the organization 15 years ago, it was small. I had like holiday parties in my living room because it was like 12 to 15 people, and it was a very small organization. It's grown. I mean, we're nationwide now. I'm in the Sarasota and Northport locations, but we have clinics, over 30 clinics all across the country. And the primary mission, as you've said, is taking care of people with HIV, not just from a medical standpoint, which is what I do, but from in terms of mental health. We have psych services, we have counseling services, there's a dentist, case management, finances, finding housing. So that is actually what drove me away from private practice infectious disease into the clinic setting, because I feel that embracing all those needs is so important for patients. But over the past couple of years, we've also expanded to include the treatment of all sexually transmissible infections. So gonorrhea, chlamydia, syphilis, and most important, and as you mentioned at the beginning in this community, hepatitis C. And we provide HIV prevention. So the term for that is PrEP. Some of you might have seen, but it's prevention therapy for HIV. So all those things are involved at most of the clinics, but that's specifically at the Sarasota site.
And the can, some people might be familiar with because of an event every year that they sponsor, which is just, which is on the calendar of Sarasota events, one of the biggest events of the year, which is their can dance, where they get local celebrities who—
We're not going to go there.
local celebrities who, so you think you can dance, they train them and they spend months preparing, and then they compete against each other. And we have with us today one of the winners of the can dance competition. And Dr. Schreibman, I'm going to pull up some video footage of your routine in just a second. No, that's not true. I am not going to do that. I don't even have video footage of that. But she won, so she is multi-talented. Let me just ask one more question. You said something interesting to me, and I wanted to ask if you would please share it with everyone else, that that some of your AIDS patients are feeling some sense of deja vu or worse as they're facing fears of coronavirus. Can you address that?
Yeah, we've had a lot of calls, and very early on in March and April when this started, we just canceled all of our patients because we figured it was going to be a couple of weeks and we would just reschedule their appointments. But obviously that didn't happen, and we've ended up converting everyone pretty much to telehealth like this, or we have some people coming on site, and we realized how important it was, not necessarily even in terms of keeping up with their HIV care and everything else, but just how scared everyone was. And I think being amidst another pandemic, like they felt like it was back in the 1980s when there was so much uncertainty and when they were locked away and when they couldn't come out. And it just has brought back a lot of memories. And I don't know if you've heard as much of this, but I've heard that is the case for some Holocaust survivors as well.
I want to ask you now, going back a number of years to your work in Africa, and I understand that your husband and at least one of your trips joined you in that work. What were you doing in Africa? What drew you to Africa, and how were you able to help?
So we, as part of our residency or training program, they allow you to go away for a few months and train in an underserved area. So we were stationed on a mission actually in Tanzania, Africa, over the years 1999 and stretching into 2000. And it was just probably the most eye-opening experience from a travel perspective that I've had. It was just, eye-opening in many ways. But from a medical perspective, it was largely just to see what we have here and what they didn't have there, and to be able to provide for people. Someone has a cough and you can't just order a chest x-ray, order labs, and throw a new medication at them, because we didn't have any of those resources. So it was a matter of really listening to people, of fine-tuning our physical exam skills, and truly of just being able to give back to a community. And it is such a beautiful place and just such beautiful people. So it was, it's hard to imagine travel right now. And it's a trip, actually one of our trips we had hoped to take this summer was possibly to go back and bring our kids to climb Kilimanjaro, which was part of one of our weekend trips there. But it's a beautiful place.
So I want to transition now to talking about COVID-19, but letting everybody know that once we get past the formal questions, we'll all have chance to to ask Dr. Schreibman about her AIDS work or anything about her infectious disease specialist a little bit later. So before we talk about COVID-19 specifically, can we just ask you just to tell us about coronaviruses, the ones with the crown, right?
Sure.
What makes them special in terms of their structure, their transmission, their behavior? Can you just tell us about the class first before we focus on the specific COVID-19?
Sure. And as you pointed out, coronavirus is simply, the coronaviruses aren't new. There are 7 different ones. And as you pointed out, the reason they're called that is when you look at them under a microscope, the capsule or like the shell around the virus has little crowns on it. And that's why they're called coronaviruses. And there are 7. There are 4 most common are just cause, or not the most common, but 4 of the older ones were just causes of a common cold. And certainly they didn't get the attention that the more recent ones have, or some of the more lethal ones. And then the other coronaviruses that many of us have heard of, there was one in 2002 that was identified, which was SARS, the first SARS, or severe acute respiratory syndrome. And then in about 10 years later, in 2012, was MERS, which was the Middle Eastern respiratory syndrome. And now this current one, what we call COVID, just in terms of the talk of it or the lingo, what we call COVID-19 is coronavirus disease 19, but it's actually caused by the SARS-CoV-2 virus, which is severe acute respiratory syndrome coronavirus 2. So they are, I guess once I get into the SARS-CoV-2, that's where you get into the uniqueness of this virus. But the only reason it's called this novel coronavirus, the word novel is just that it's newly identified. And it wasn't this newer with this SARS-CoV-2 or the virus that causes COVID-19 wasn't identified until December 2019, when it was originated in bats in Wuhan, China. And that was when the virus was identified. And the reason why it's become a pandemic is largely that no one had been exposed, so no one was immune. So it was kind of set up the perfect storm, along with many other characteristics, which I can move on to that if you want me to.
Please, absolutely. That was my next question, so go there.
So I think the main, I knew you were going to ask me that. I think the main one to distinguish from what keeps coming up and what everyone asks about is flu versus COVID-19. And influenza is not a coronavirus, but it's a virus that causes the flu. And that's what it kind of keeps coming up over and over. What's the difference, and why is COVID-19 doing this, and why is it become a pandemic? And I think both influenza and SARS-CoV-2 or COVID-19 cause respiratory syndrome, shortness of breath, fever, cough, respiratory symptoms. But there are a lot of differences. To me, kind of the 2 big ones to highlight. The first one would be transmission. And it is just, flu is contagious, but it pales in comparison when you look at COVID-19 and its transmission. And I think part of that, or a large part of that, is just related to how much asymptomatic transmission there is. So people that don't have symptoms that are transmitting the virus, and it's thought, these numbers change all the time, but it's thought that probably 50% or up to 50% of transmission is via asymptomatic people. And for example, you can have COVID-19 and recover, but for up to 10 days after you no longer have symptoms, you can still transmit virus. And by the same token, you can be exposed or know you had an exposure, but you may not have symptoms, usually 5 days later, but it could be 2 weeks. So there's these long periods of time where people are asymptomatic, where they can still transmit. And I think that's just laid out the groundwork and the framework for this pandemic and this high rates of transmission. And then the other big factor, and again, there's lots of differences, would be just just how deadly it is and the lethal nature to it. I mean, not even just the death rates. It's so hard to pinpoint a death rate for influenza. We know it's probably less than, I mean, it's horrible to have the flu. I've had the flu. I'm sure many of you have had the flu or know someone who has. But the fatality rate or the death rate is less. It's probably 0.1%. It's way lower than 1%. And it's impossible to say where we're at with COVID-19 because we don't even have an accurate number as to total number of cases. So it's hard to figure out a death rate, but it's higher. I mean, it's coming out to 4 to 5% right now, somewhere between 4 and 5%. It may be lower than that because there's so many undiagnosed cases. But even if people aren't dying, they're so sick. I mean, you can be asymptomatic and you can, 20 to 30% of no symptoms, 20 to 30% mild. But there are a lot of people who aren't dying that are intubated, that are short of breath, that can't breathe, that require ICU admissions. And that's very different. It's very different from influenza. And those two things just kind of set this perfect storm scenario for a pandemic. If you have something like the Ebola virus, for example, that is like a 90 to 100% fatality rate, everyone dies. You can't transmit it because people aren't living. But something like COVID-19, people are really, really sick, but they're transmitting virus, and that's kind of why we're where we are now in this pandemic. So I hope that answers it. But there's a lot of differences. But to me, those are the two big ones.
Actually, by answering so clearly and so briefly, that's actually what we most need. I mean, we're all inundated with information. We can't get enough. We read, or watching on television news and so forth. So it's really nice to sort of come back to you and remind us about sort of the essential things, like, and so that clarity, thank you, is really helpful. So then let me ask, you are not alone in this field of infectious disease. So you have peers, and I imagine there's message boards and phone calls, and that you are talking with other people in your specialty. How do people, your peers, other experts, feel about COVID-19 and about the American response?
So, I mean, it's to look at where we are now as a country. I mean, whether we're talking about my peers, my medical peers, or my friends, or any of us, I mean, it's just to compare where we are as a country and look at any other country in the world, maybe with the exception of Brazil, we're failing at conquering the virus. And, Sarasota Memorial, the chief medical officer there, has put statements in the newspaper, and he was actually on national television on CNN making statements and we as physicians have all gathered together and written letters, a petition to the governor to ask him to, implore to have a state mandate requiring masking. So there's some very simple solutions not solutions, but ways to mitigate the spread of the virus, and we all know what they are, but through masks, through hand washing, through social distancing. But we still need a government, whether it's on a national level or a local level, to help instill that in people, to know that it needs to be done, because it just otherwise isn't happening. And I think that's why we are where we are right now. And the hospital we have a task force at our clinic, and I'm involved in that. The hospital has a task force, and they've been amazing about keeping us up to date and about getting personal protective equipment and staying prepared and having a backup. The ICU is almost full now, but they have other beds that they know they can turn over, because we've seen what's happened in New York and other hotspots. And we're all really nervous. I mean, I think we're as prepared locally as we can be, but as we all know, there was a record high in Florida yesterday of over 15,000 cases, and it is very scary.
And just to clarify for all who are participating here, that record is not just a Florida record. That record surpassed New York. Now, of course, New York at the time didn't have as much testing, but the number of new cases that Florida achieved over this past weekend, suffered, I should say, is higher than any other state has ever had in a single day. We are worldwide, we are one of the Sarasota County specifically is one of the hotspots right now. So then my next question, I want to get a little bit more personal. Many on this call in our congregation know your husband, Dr. David Schreibman, who's one of the leading cardiologists in town and treats many of our members. We have many members who thank him for saving their life. So he's very popular with our crowd. The two of you are very attuned to the medical community in town. You are, you are partners or close friends with dozens and dozens of doctors, you nurses and other people. Tell me, what is the climate of medical professionals in Sarasota? Are people scared? Are they nervous? And how are your professionals in Sarasota feeling?
Yeah, I think scared and nervous. I mean, he's in the hospital a lot more than I am. And I mean, it's driven us to the fact that we, other than going to work, we really don't leave the house. And it's been very scary. I think early on, it was just almost surreal to go into the hospital and see people in gowns and masks and eye gear. And part of it was just, it almost felt surreal. But then we only had a handful of cases. So it was more just, it was actually reading about it in New York and then seeing it a little bit here. And in fact, when you asked me to do this, it was 6 weeks ago and we were still seeing some cases, but then it kind of petered out. And I was starting to think, we'd be talking more about HIV than about COVID-19 because it seemed to be the numbers were declining. And now it is just, it's no longer, all of us worried about when we might see it or people calling saying they're worried about being positive. People are calling because they are positive. And, he's downstairs seeing patients in the other room in the house. And all the patients are scared. The staff are scared. The chief medical officer sends emails every day imploring us to implore our friends and our family and anyone out there that we need to take this more seriously. I don't mean that to people listening today or to you, but just to the community and to our government.
And I should also mention, to everyone here, this call, she was supposed to be and at her clinic. That's where we had set up the camera and everything, but there was a change and suddenly we had to relay code to your house. What happened at the clinic?
It was actually someone it wasn't at our patient site, but at our administrative site, someone on the executive team tested positive for COVID-19. So, and that's where I had planned on doing it, was our executive office. And so the whole staff, I wasn't physically there. I was at my clinic, but I didn't want to go over there, and they've cleared out and everyone's being tested, or everyone was tested. And, as usual, no one will get results. As people were asking before this call started, it seems to still be taking at least 8 days to get results. So until that time, we don't know when people can go back. But there was someone that was positive and they're doing okay, but it's led to an exposure.
Yes, so here we had this program on COVID-19 that almost got that got
Right.
disrupted by COVID-19.
Right.
But we're grateful that you were able to rearrange and co-opt your daughter's bedroom and make it so that you could be with us today. I'm looking down, I only had 2 other questions before we open up the floor to everyone. You and Dr. David Schreiber, you and your husband, you're 2 of the smartest, most knowledgeable, most conscientious people that we know. So, how do you apply that to your own personal life in COVID-19? What are personal choices that you are making and how you navigate for yourself and for your own family?
Yeah, we've been really, really cautious, even just from the very beginning. And really, other than it's Dave and I here, and then our 2 teenage kids who both have birthdays this month, so they're turning 17 and 19, or turned 17 and are turning 19, and we've just been home. And I mean, and we've tried a socially distanced. My son tried to get together with some kids in a socially distanced way, and it's just impossible for that to happen for that. We felt for them from what we saw. And so we've just been very strict. Thankfully, our kids have been respectful and understanding of kind of our home mandates, but we abide by it too. I mean, we're doing curbside for groceries. My daughter, Alana, cut Dave's hair. He really needed it. I really need it too. So she might be onto my hair this weekend. And we really haven't done anything since March. And I guess the silver lining in that is that we've had this time with them that we won't get back, because my daughter hopefully will be going off to school, and you know they're teens. They've got 1 foot out the door, or almost 2 feet out the door. But we've been extremely cautious, and I think some of that is just seeing what we both see, and especially for Dave, who's in the hospital setting, and knowing that we're at higher risk. So it's not just that see people out there. It's actually much less that. We worry so much about exposing other people, and because we're home with our kids, if they're with their friends, and then their friends go home and are with their parents and their grandparents, we worry about exposing others as well.
My last question is if you just have any final word. You seemed hesitant to caution us to be more careful, but take off the gloves and tell us straight what like last word you want to make sure that we all hear.
Right. It's so not my personality. I'm like that with my patients too. Like I've had people say, I need you to be more, more firm with me. I have to say, I mean, yes, we definitely all need to wear masks and socially distance and wash our hands. And I know I have to say that, but to be honest with you, I think what I find just as upsetting with this pandemic is it has affected everyone. I mean, we all know everyone is I mean, whether people have lost jobs, lost lives, gotten sick, know someone who's sick across the world. And there's so few times in history where that's been an issue. And you would just think it would be a time where we would unite. And I mean, that's, the virus doesn't care which race you are, what religion you are. It certainly doesn't care about your politics, but yet we're more divided and angry than ever. So to me, it just seems like it would be a time where people could unite. And it seems like the only path in terms of moving forward for us as a community and as a world to conquer the virus. So I don't know, that's I guess that's my, maybe that's the idealist in me, but I feel strongly about it. And it seems like such a sad thing on top of everything else to have everyone so angry and at a time when people need to be comforted and need to be comforting each other and supporting each other. So my hope in moving forward, whether that's through a new government or whether it's through people opening their eyes, is that can happen on every level.
Well, before we open up to questions to everyone, I wanted to speak on behalf of everyone to say thank you. We asked if Dr. Schreibman would receive an honorarium today, and she declined. She said she wanted to. I hope you would allow us. Our congregation will be making a contribution to the CAN Community Health and to help support your work and the work of your peers there. But please know that that's simply a token of our appreciation for you sharing so generously of your wisdom and your knowledge with all of us and your time. We are very grateful.
Thank you.
So let's go to our questions. I'm going to go ahead and just start with the questions that are in the chat. We have 2 questions right off the bat about schools. Wendy Wicks asked, how can we possibly consider going back to schools at all levels, given the transmission and the length of time that someone can transmit and not even know? The other question comes from one of your best friends, Rabbi Elaine Glickman. If the governor, who's demanding that all schools in Florida open up in person, not online learning, if that's the case, what are you going to do with your, student at Pineview from another mother at Pineview who is really desperate to know?
There are great questions, and I have a feeling a lot of these are going to be questions that I hope I can answer. There are so many unknowns, but we filled out the same survey that I know any parent that's listening in Sarasota County filled out, which is what would we do? And we filled out online. I mean, I hate the fact that the kids aren't in school. I mean, it's awful in terms of socializing and in terms of learning, and the online course thing just didn't work very well, really, for anyone across the nation, as far as I could tell, and from all my friends that I spoke with in other states. So I would love to have the kids back in school, but I agree. I don't know how it can happen. We not voted for, but elected for the online learning, if it were an option. Although when I looked at how that survey bore out, it looked like 80% of people said that they would send their kids back. I mean, the fact that this push to go back to school came, and the opening of Disney World came, at a time where Florida is surging as with record high cases, is unbelievable to me. I don't think they're ready to open up the schools. If they do, and there's the option for online learning, it's going to have to be a big discussion in the household, but I think we would opt right now for online learning. It's in a month for Florida kids to go back. And I don't feel like it's safe, both in terms of our son exposing others, and in terms of others exposing him, and thus us. And I also can't imagine it would work. I feel like the schools would go back and there would be an outbreak, and then all the kids would have to go home, and I feel like we'd be back. So I don't know the answer. I know just today, or a couple of hours ago, California, I think LA and Seattle, or LA and San Diego, I'm not sure if I have that right, but 2 places in California I know announced that it would be online only learning for the fall. So it may be that we start to move in that direction. I'm not sure what will happen, but we have a different governor than California. So yeah, I don't have the answers, but we would probably not send our son to school right now.
And just as a point of information for people on the call who might not be aware, the Temple board, after 3 weeks of intense deliberation, just last week decided that it would not be safe to open up the Susan Schwade Early Learning Center, our preschool on campus. We tried a number of different ways to figure out how to have a safe preschool, and none of them were sufficient. So that's a tough time for the Temple right now, and all of the families who need childcare and want learning, and we want to be able to teach, but we just don't feel we can do so safely. There's a series of questions about vaccine, and one is, how long do you think? The other is, if people's antibodies are fading away in time pretty rapidly, would a vaccine have a long-lasting effect, or would you have to keep retaking this vaccine? Do you have any sense of about a vaccine that you could share with us?
Yeah, I think that's been the hardest part. It is so hard to develop a vaccine. I mean, when we look at, even for influenza, our vaccines change every year, and they're not always, some years are more effective than others. I think something like HIV, we still don't have a vaccine, and they've escalated and moved up the time course in terms of trying to come up with a vaccine. We're still a long ways away. I don't think it'll be this year. I'm hopeful in 2021. But then the other question is how will that work? Because right now we don't even know if someone is positive, and if they develop antibodies, we don't know for certain that they're immune. And that's actually where the tricky part of developing the vaccine for COVID-19 comes in, is how it will work. So unfortunately, we do not have the answers right now. I mean, they are using convalescent plasma, which is, the blood or the plasma from people that were positive for COVID-19, and then are giving it. The last patient I saw before we came on the call actually received it. She was admitted to the hospital and received convalescent plasma, and she got a lot better. I don't know. Hopefully maybe it was because of that, but that kind of goes hand in hand with the concept of the vaccine and of the antibodies. So I can't give you a good answer. I wish I could give you a better one, but there just isn't one. But I think we're a ways off, and I think they're moving as quickly as they can. but vaccines are for viruses in particular are really, really difficult and time consuming to develop.
I want a better answer, Dr. Schreibman.
I'm sorry. I was nervous about the questions.
I wanted a more cheerful answer.
No.
That we'll have one next week and it'll be the panacea we're all dreaming of.
Right. And then you can all say, what was she talking about? I hope you're right.
Yeah, well, I think you're right. I'm just telling you what I'm hoping.
I know.
The questions on the chat, of course, are coming faster than I can ask them, but we'll try to get through a bunch of them. Someone here, a very practical one. What is the appropriate protocol for using masks? Reuse, liners, storing after use, etc.
Yeah, washing. I mean, really, the masks, the cloth masks, and because it doesn't have to be a hospital mask, and the cloth masks are better because they can be washed. So often people will say, you know, to have 3 of them, and then you wear one, and when you come home, you can wash that one and have the next one available. But generally speaking, you know, the safest way and the way to be, you know, to keep it clean is to put it in the washing machine after you've used it that time. So, but again, it does not have to be, the hospital masks are no better. I mean, there's the N95 masks, but that's not recommended for community setting and they're impossible to get anyway. But a cloth mask just can be washed and should be.
Thank you. That question was from Rabbi Mimi Weiss and from Paul. The next question from Randy Wynn. Please explain the recent controversy in airborne transmission. Is it safe to enter a room with a person who was not wearing a mask?
Yeah, it's a really good question. And again, it's not the thought, I mean, so there's this distinction between droplet and airborne, and droplets are bigger, you know, bigger drops. It makes sense. And it's more through sneezing, through coughing, through talking, through singing. And that's where the whole 6 feet of social distancing comes in terms of droplet precautions. Airborne means when you walk into a room, you know, whether it doesn't matter how far someone is away from you, because it's just in the air. They're much smaller particles. Like the classic is tuberculosis. And that's why when someone has TB, they're isolated in a room, whether it's in the hospital or wherever it is, because it can spread through the whole building. And that it's still not clear. I mean, it was just over the weekend that the WHO set out new concerns for whether this would be airborne. My feeling is it has to be. I mean, I just think we don't know enough yet. It was kind of like early on when we didn't know about masks, and it's just so evolving and it's changing so much in terms of our knowledge. I don't know how it couldn't be airborne, where it's so it's transmitted it's just so contagious, where we're seeing so much transmission. And that's why when, you know, we're seeing these large outbreaks after people are at large gatherings. So again, it's definitely not scientifically stated yet, but my feeling is that it is also airborne. And is it safe to be in a room with someone else when they don't have a mask? Probably not. I mean, it depends who it is. I mean, in our house, you know, we don't wear masks with my kids and my husband, but when I, you know, go to the clinic and see patients there with this, everyone inside are wearing masks. So I think in grocery stores, which, you know, I am not going to, but you have to, you know, and so certain things have to get done. And my kids had to go to the eye doctor last week, and, you know, we all wear masks. I mean, you have to now. It's thankfully in Sarasota, the city of Sarasota, at least they are mandating that, for what that's worth. Hopefully they will in the county. But I think it's not safe to be inside with someone that you don't know that isn't wearing a mask.
Next question. By the way, thank you for each of these questions. The next one comes from Andy Hirschfeld. Is elective surgery at the hospital or an outpatient center safe right now?
I think anything elective should, safe, probably not. I would avoid anything elective. You know, again, we had to go to the eye doctor, but we canceled our dentist appointments because it didn't have to get done. It's the flip side of that is we're seeing a lot of things getting put off on the back burners. And, you know, over the past 4 months, any cardiac catheterizations or any procedures like that, or diagnoses of acute heart attacks or all kinds of medical diagnoses, have all declined. And it can't be that we're not seeing heart disease anymore. It's that people are afraid to call if they have chest pain or afraid to go to the hospital and not addressing things. So there's a very fine line. I'm not sure what procedure you're talking about. So I really hesitate to say don't do it, because some things should get done. But if it's something that's elective, which how you're describing it, I personally, I would wait if it can, and if you think it's safe, and if your doctor thinks it's safe. Along those lines, I think we're going to be moving pretty quickly, and many of the hospitals in the area are. SMH has not yet, but they were at a time where they were not doing any elective procedures a few months ago, and I suspect we're moving in that direction. And a lot of the other local hospitals in Pinellas County and other surrounding areas have already made that statement.
All right. Before I answer the next question, there's some interesting information put up on the chat by one of our Temple members, Steve Levitt, who says that tomorrow there is a Sarasota School Board workshop starting at 10:30 a.m., including the agenda is the reopening of schools. And then later at 3, the board's going to meet and discuss again the reopening of schools. And he put their links for those two meetings if you want to be involved. Either I don't know if you can participate or just watch, but that's in the chat if people are interested. New question from Diane Arch. How effective are the new medications for treating COVID?
So not great. I mean, one of the most widely used one now are just simple steroids, which we use for a lot of different lung diseases. And those have been somewhat beneficial for people with more severe disease. But for people with mild symptoms, there really isn't anything that we have to treat or that we can do. And because I know again, just this morning I was on with another patient whose husband tested positive, and he asked me, what can I go on now? What could you treat me with? And there's nothing in terms of prevention other than clearly staying away and distancing. But in terms of treatment, remdesivir was one of the antivirals that is being used. Most of them, all of them are really through study use. The convalescent plasma that I had mentioned before is taking blood from people that were positive for COVID-19 and then using that blood, which then has antibodies for treatment. So most of the treatments, or all of the treatments really, are primarily through clinical trials, and the patients are hospitalized and the patients are really sick. But for patients with mild symptoms, and I have many of them, they're at home. And it's just, I think that's also another thing that's just been so scary for people, is that they don't know what they can do. And there isn't that much that you can do. And it's usually kind of day 9 or 10 where people get a lot sicker, and that's where we're checking in with people. And the answer then is to go to the hospital. Just if it does happen to anyone on the call, at that point it's not safe to be at home. But for people with mild symptoms, the answer is quarantining and temperature checking and monitoring oxygen are really the main things you can do. But there are not a lot of drug treatments currently available. I think New York just sent Florida a shipment of one of the antivirals that we're trying to use, but they're limited supply. And in terms of efficacy, it's not great.
Is it safe, this is from Sally Steele, is it safe to go in the ocean or to go in a pool?
I do think I would think that that's safe. I mean, again, it's the beaches make me a little worried, just because there's so many people it's been more crowded in terms of the photos that I've seen anyway, and you run into the bathrooms and all the other issues. But I think exercise is great right now. I think it's great for mental health. I think it's great for physical health. And I definitely wouldn't worry about the COVID-19 in the water. That would not concern me, especially like a body like the ocean. And I think even I was never asked that question. I haven't thought about it in terms of a pool, but I think a pool setting would make me a little more nervous if it's your own pool, of course. But if you're going to a public pool, it just makes me nervous, just because by nature of that, you have people in closer settings. But I don't think the water itself would be an environment that would be of concern for COVID-19 to be living in. So that the water per se would not be an issue.
follow-up on your advice about, you said no to the dentist and yes to the eye doctor. So I think people want to ask you a little bit more about that, including Stephen Schreibman. When you stated that you would not have elected procedure, would you also include mammogram and colonoscopy in that recommendation?
Well, I know that's a little bit of a loaded question from a family dynamic issue, but I have to say I'm going to get in trouble with this one, but I would put, I had my colonoscopy last year, so I don't have to worry about it, but I would put off things like that right now, unless there was a concern. If someone was having bleeding or someone had a lump, of course, I think those things need to be addressed. But if it's just a routine testing, I wouldn't do it. I'm sorry.
Okay, so that was the most recent question. I'm going to go back. Dory Goldfarb had asked a question that you had already addressed, but maybe you can address it with a little bit more detail.
Sure.
She said, how long can a person be contagious if exposed and not showing symptoms? So let's say you have a family member who was with somebody that they might have been exposed, or they were at a party or something. Like, how long would you worry about that person who's showing no symptoms?
So on average, 5 days is the answer. Someone usually would show symptoms within 5 days, but it can be up to 2 weeks, 14 days. So usually if someone's called and said they were exposed and they're worried, we would tell them until day 14 after that exposure that you need to, that's where that self-quarantine term comes in. So 14 days.
Thank you. So now I'm going to look out, because not everyone uses the chat feature or is savvy to it. So I'm looking now for raised hands. If anyone wants to ask their question directly. The first hand up I see is Barbie Comans. You will go first. Please unmute, and others keep your hands up. And while she's asking, I'm going to be looking for other hands. So Barbie, you have the floor.
I just wanted to know, when somebody's been exposed, how quickly will it show up on a test?
Well, if you've been exposed, you might not test positive. Just because you've been exposed doesn't necessarily mean that you'll, it has a very high transmission rate, but certainly there are people who are exposed to people who have COVID-19 and they don't become positive. So you don't necessarily become positive, but for up to 14 days after your exposure, you could become positive. And as soon as you have it, sorry, go ahead. Did I not answer?
No, that wasn't me. Somebody else must have.
Oh, okay. Then in terms of the testing, if it would show up right away, because it's a swab that goes right, the actual testing for positivity goes right down your nose, and it's testing for the actual virus. So if you have the virus, that test is going to be positive. There isn't, it's not like an antibody. That's the blood test that checks to see if you are exposed. That can take time to develop an antibody. But if you've been exposed to the virus and you have it, that swab is going to come back positive on that day, if you've actually got the infection. And you may not have symptoms, but it could still be positive. One of the problems is that test that you get, and that's what everyone's waiting in line for at UTC and all the different testing points for hours to get the test, it usually does take at least a week to come back. There's some hospital cases where they have rapid testing available for more severe cases, but generally right now what's available takes a week.
So if somebody were
Barbie, I'm sorry, we've got a big line of people. I'm sorry. Lynn Sachs, and then Wendy Wicks, and then Marnie Mount, and then is that Jay's hand or Sally? Jay's. So Lynn and then Wendy.
Thank you, first of all, for all the efforts you put to make us more aware of what's happening and your perspective on it. I really appreciate everything you said. I have a very mundane question about takeout food. We've been taking food out from restaurants, and I'm nervous about that. How do you feel about taking food out from a restaurant?
I actually think I get so nervous about answering these questions because we don't know for certain. but the likelihood of it being on an object, on a surface, that was initially of a bigger concern, but it's pretty unlikely. It's not going to be in cooked food. And the likelihood of someone cooking it that was positive that could then transmit it to the food, I think it's safer than going into a grocery store. I think probably the bigger risk is the delivery person, but usually right now people will leave it at your door so you don't have to have contact with them. And then, taking it out, the food out, and then washing your hands after you've touched the packaging that it came in. But the food itself, I really think is safe from what we know.
Thank you.
Sure.
Wendy Wicks and then Marnie Mount.
Many of us have children and grandchildren all over the country. The question, actually, it's a two-part question. Is it safer to drive or to fly, knowing that with driving there's hotels and stop-offs in various places, especially if like my family's in New England, for instance. It's a 4-day drive the way we drive. So is it safer to go that way? And then once we get there, of course, Massachusetts and some of these other states want us to quarantine for 14 days. So we have 4 different clusters of grandchildren in different homes. Would we have to quarantine in between meeting with each one of them in order to feel safe and not feel that we're spreading between members of the family?
Yeah, this isn't the answer you're going to want to hear, but technically, yes. I mean, that to me is kind of the biggest concern with people with it spreading, is that it could, because you could be with one group of grandkids and one of the kids is positive, because we're seeing so many younger people test positive. Those are the highest rates of positivity testing that we're seeing now, and could have exposed you, and you unknowingly then go and see other grandkids. And that's kind of how it's been spreading. So I know it's not the answer you want to hear, but technically, yes. Flying versus driving, I don't know. I mean, I think I'd still vote for driving. You do run into that issue of the hotels, but it makes me nervous. I mean, people have to do what they have to do right now. And if you have to get on a plane, chances are it's fine. It's just, if you can avoid it, I would vote personally now for driving. And it sounds like you've done the drive before, so it's not something that, that you mind doing. I'd probably shoot for that, and just, and at the hotels, just stay away from people, minimize, social interactions, and wash your hands and wear masks, and you do the best you can do. And people are doing it all the time. So, but I would vote for that over flying at this point.
Based on what you're saying.
Okay, Wendy, I'm sorry. We've got so many people in line. I'm going to need to move on, though. Marnie Mount, it's you, and I forgot who else I had called on already.
Jay.
Yes. Marnie, you're next.
Hi, Marnie.
Hi, Tanya. So my question is, we both have daughters starting college this fall. There's a lot of parents I know who have already canceled their dorm contracts. The parents are having the kids or the kids have chosen to stay home and not go. We're very mixed here about, we're terribly fearful, but I do want my child to have that freshman experience. Whatever it is, it will not be what we had. What is your feel about sending your child or any of our children to college this fall?
Ready? No.
Yeah, it's, oh gosh, I'll try to make it short because I know we're tight on time. Remind me, where is Natalie going?
Going to go to FSU, and they do have a pretty decent plan there, and a clinic on campus that tests the kids, and the very clear description of what they're expecting of the kids in the fall, right. And most online classes.
Yeah, right. So that's where a lot of is at. My daughter, who starts college next year, we're planning on having her go. To me, to have all online classes and to be in a dorm room by yourself, no roommate, having to wear masks, temperature checks, no, cafeteria or dining options. To me, I feel like she'd be better off not spending the money and being at home.
Right.
But she's okay going, and she wants to do it. And I feel like it'll still be a college experience in their own way. And maybe kind of like getting back to the whole sense of community thing I was talking about before. Hopefully they will bond together and rise through this. I mean, we need their generation.
Yeah.
So we're letting her go, which I know is counter to what I said before about my son, but we've kind of taken 2 different approaches to it. And I don't know if we'll have choices, but assuming her school still opens up, which I think they're planning on it, it'll be online classes, but she's planning on living on campus. She has to get to Pennsylvania. I think we'd probably drive before flying her up there now. And I don't even know if we can go to move her in, but so
All right,
I'll be.
we're now in lightning round. We're going to go quick staccato,
Sorry.
Jay Steele, and then Carla Raines.
Just because you test negative for COVID, it doesn't mean that the very next day after you take that test, you could contract the disease. Am I right?
Correct. Or you actually might have it, but the testing was inaccurate. So if you test negative, it actually doesn't mean you don't have it. It changes every day again, but somewhere around a 30% false negative rate. So false negative actually. So the test is negative, but you actually have it. So we don't really, I don't think we see a lot of false or any false positives, but so yes, you could be negative one day and then get the virus the next day, or you could be negative one day and you actually had the virus that day, but the testing wasn't accurate. A lot of it depends on the person performing the test and how deep they get down into it's not a comfortable test. It can depend on the lab and it just depends on the processing, but it's not, unfortunately, a perfect test yet.
Dennis, you're next.
Yes. Some people are asymptomatic, others are extremely sick. Is there any understanding as to why it affects people differently? When you get the flu, you're sick. But when you get this, you'd be walking around, never know you had it.
I know. It's actually kind of the third thing that I meant to bring up when Rabbi was asking about the differences in flu versus COVID-19. Thank you for pointing it out. And you're right. And I don't know of any other pathogen or virus or bacteria that causes such a wide spectrum. So probably the numbers break out to about 20 to 30% of people have no symptoms, and then maybe around 4% die. And then there's this middle ground, but there's a large percentage of people that do get very, very ill. It's definitely, it's not fully understood, but it clearly is in usually people that have underlying health issues. So which is why, older people have been more sick and clearly die more. And that's the whole issue with spreading now is younger people are asymptomatic. They're feeling fine. They're not scared, but they're spreading it to older people who may get sicker because not just because they're old, but because they have chronic medical issues. And that's why this lag in the death rate, we're worried about a lag in the death rate, that is going to crop up. So I think most of it though is not just due to age, but in people that are older, we see lung disease, you see high blood pressure, you see heart disease, people that are immunocompromised, and those are the people that get sicker. Usually in someone younger and healthier, you're not going to have the same symptoms. So that's the biggest way to differentiate.
Thank you. Say thank you.
All right, we're going to go to Sally Steele, which will be our last question. I didn't see any other hands, but if you did have your hand up, I'm really sorry if I missed you. Sally, if you could go ahead and unmute yourself.
I will do that. Thank you. Thanks, Tanya. This has been
Sure.
so interesting.
Sure.
I had read that people with A positive blood seem to fare more poorly than people who don't have A positive blood. Can you explain why that might be?
I cannot. I am so sorry. I don't want to say something that I'm not familiar with. I have actually not seen that. I will look into it and I will get your contact information from Rabbi. I do not know, and I can't think of an explanation as to why that would be. No, I'm sorry. I can't answer that.
Well, thanks for trying.
Yeah.
The New York Times, I didn't read the article yet, but the headline, one of the headlines today is how how fatality rates are higher based on race, age, gender, so many different factors that it's not just randomly one person or another person, but it seems to be targeting or affecting adversely particular classes of people in such devastating ways.
Correct. And that's why in South Carolina, you probably saw the fatality rate was so high over the weekend. And a large part of it is the population there that it has affected. So I agree.
All right. So honestly, we could be here all day because we wish we had you in our family and we could just ask you these questions all the time before we go on a trip or see a desk doctor, and we could just get your advice. We are grateful, though, to have had today to have this. So what our custom is with this is we conclude the program, and I'm going to stop the recording in just a moment. And then those who have to leave can go, and those who want to stick around and discuss, you are welcome to, even if it's just talking about ourselves. If Dr. Schreibman has to go, you're all welcome to stay. But I did want to wrap it up formally, and just to say from all of us at Temple Emanu-El, very special thanks. The daughter, who is on her way to Penn, by the way, became a bat mitzvah at our very own Temple Emanu-El, and now look, she's all grown up and on her way to college. Please, before you go, unmute yourself. We just lost visual of Dr. Schreibman. There she is.
Because my phone said I was on low battery. I have to plug in my phone.
Oh, okay. Go ahead and offer, before you go, you're welcome to unmute and say a word of thanks or goodbye.
Thank you.
Thank you.
Thank you.
Thank you.
Thank you.
Thank you. It was terrific.
Thank you, everyone.
Thank you very much. That was a wonderful.
Thank you.
Thank you.
Thank you.
You're so welcome,
Thank
everyone.
you,
Thank
thank
you.
Thank you so much.
Could I just ask you, can you hear me?
I can. I'm just, while we're talking, I'm plugging in my
just
phone now that we're in the
hold
forum.
up just a moment, because there's still a few people who want to say farewell before we go to the next question.
Yes.
How does a pandemic play out? If antibodies don't last and people are getting reinfected, how will this ever end?